So as we go into metastatic castrate-resistant prostate cancer management, that is gradually shifting and the paradigm is changing, mainly because a lot of patients come to us now in the castrate-resistant state, which have already been pretreated at a minimum with ADT plus an oral, and we heard the extensive discussion before, and sometimes even the triplet of chemotherapy. There are a number of trials that are even looking at early use of PARP inhibitors in the HRR mutation patients. So again, that may be a different type of patient population, and this patient population is rapidly changing. So what should our approach be? And maybe we can start with patients who are just pretreated with ADT plus an oral, and what do you consider in them? Okay.
Well, the good thing is that we have a number of different options now to treat our patients with castrate-resistant disease that weren't previously available. So obviously, if they've been pretreated with an oral agent, the considerations are chemotherapy, docetaxel chemotherapy, a PARP inhibitor if they have a BRCA DNA repair mutation. Now, because of the PSMA-4 trial, we could consider PSMA lutetium.
Yes.
And Xofigo radium, it would be another consideration at some point in the castrate-resistant setting. And then obviously clinical trials are always important in this setting as well.
So there is, Frank, can you talk about the PEACE-3 trial with radium-223?
Yeah. So a really interesting trial, showing. So this was a trial that took patients with not treatment intensified,
Right.
but
Only
upfront ADT,
Correct.
but they did better with radium plus Enza versus one of them alone. So a really intriguing trial. I think it informs how we may use those drugs going forward. But yeah, hopefully we're going to see less and less of that patient population, as time goes by, and the quality care metrics improve, and we see less patients that were upfront treated with ADT low.
Right. Now, I mean, you're right, it is a very intriguing trial because the control arm was very, very powerful. In mCRPC, if you're using a frontline oral agent, that is a very powerful treatment. And despite that, the addition of radium-223 showed a median survival benefit of 6-7 months. So that to me is just attractive, obviously. I mean, radium-223 is easy to tolerate. Even the patients who were not chemo candidates could tolerate it from previous studies. And should we be considering that for the patient with predominantly bone metastases?
I feel like I'm like curious what you guys do, because this is just, there's so much that changed. And then I don't feel, because I see mostly prostate, so I'm like embedded in it.
Yeah.
But then when our fellows come through, they're like, because lung cancer, pancreatic cancer, it's like very clear, this is the first line treatment, and they're just like, I'm so confused, So you can only imagine, patients and their families too. So I think the question I actually had, Ulka, when you asked that was like, well, radium versus lutetium PSMA. I think that is like a big open question that I don't really know that sometimes the patient's disease makes the decision for us. If they have, lymph node mets or soft tissue mets, then radium's out of the question. But if they only have bone mets, I don't know that we really know. We don't, if one is better than the other. And so I sometimes I'm not sure which one to choose even.
I mean, I'm a little bit torn again because of no survival benefit with PSMA-4. And that, of course, is because a lot of people on the control arm would probably get lutetium at some point down the road. So should we use the radium-223 with an actual survival benefit?
Good point.
And then later on, now there is data for using lutetium after radium-223. The VISION trial required at least 6 months between radium and the lutetium. So, but those patients, it was perfectly safe.
Yeah.
So
something to consider. I just really wish that trial would have been, the contemporary treatment, where it was treatment intensification, rather than single arm ADT.
Yeah, I think a lot of the trials have been limited by that. Like the ABI and olaparib, like the PARP inhibitor combos too. The patients didn't get what we normally give now up front. So yeah, that's been challenging, I think, for those treatments to be, part of standard of care, really. So
I must say, I have a patient right now who progressed on enzalutamide. His PSA went up to 1.1. He came in with symptomatic bone disease, and his PSMA PET just has not been highly PSMA expressing. That is the kind of patient I feel like I would do the radium instead of lutetium.
Of course, if they're not at all expressing or not highly expressing,
Low expression.
but yeah, if they're low expression but still positive, certainly, yeah, that's somebody I considered.
I mean, it is hard to interpret because the lutetium trials did not at all give us information about that.
And I guess the question I would have for you, Ulka, is how do you decide for that versus docetaxel or some other?
Yeah. I mean, this guy has a lot of cardiac disease, and so, I mean, it was like docetaxel was out. He just had arrhythmias and stuff. So that's why, this is not a chemo patient.
Because I think the question with all of these, many of these agents, chemo, the radionucleotides, is bone marrow toxicity, and how many therapies can you give any individual patient, and you want to make sure that you're giving them the one that's the most likely to be successful.
So do you have a sequence in mind for the otherwise healthy, robust patient who turns castrate resistant?
I mean, as I said before, clinical trials are always on the list there, but if that is not an option, then I would usually tailor it based on their pattern of relapse. So if they have rapid progression that's very symptomatic, I may consider docetaxel, which sometimes I find to be more rapidly palliative. And somebody else I would probably consider, PSMA lutetium or radium, as you mentioned, especially for the bone-only disease. Radium would be a consideration.
Absolutely.
it's a really tough choice. I feel like I kind of the docetaxel now at PSMA-4, it's a really tough choice. And there are some logistics to think through. I think for like real world, real life people who, so like for lutetium, they have to have like radioactive safety or whatever. So, for a patient who lives in a small home with only one, they have to have a separate bathroom from their spouse for like so many days. So if they live in a small home, they have a single bathroom, then that may not be an option. It's not safe for their partner. I had a patient opt for docetaxel because he watched his grandkids and he couldn't not be around his grandkids. So there are these things to think through, but for a true person who doesn't have any limitation, I mean, it's a tough choice. I don't think we really know which one to choose.
Yeah, I mean, I
kind of default to the older, to docetaxel.
Oh, to docetaxel? No.
Yeah, neither of them. So I mean, just because it's well,
Not the radiopharm.
well established, it has a survival benefit.
Absolutely.
Lutetium, PSMA, of course, it may end up having a survival benefit. It doesn't yet.
Yeah.
And the radium enza combo is just hard to apply to that population. So my default choice still is good old fashioned docetaxel.
One thing I would throw out there about this too, and I'm curious what your guys' experience is sometimes we do see these disease flares because it is a radioactive molecule. So if they have a large prostate tumor, a lot of painful bone mets, like our palliative care, I'm in clinic with palliative care, and they see a lot of bone met pain flares after lutetium. So, and urinary retention, from the prostate tumor, because everything's inflamed and swollen from the lutetium. So I have had this thought, and there's no data to back this up, but do you debulk them with docetaxel first, and then think about lutetium on the back end? We really don't know. But that, I think what you guys were both alluding to about if you need a rapid response or someone's really symptomatic, then docetaxel is more cytotoxic and is going to control that disease faster. So.
Also for people who you cannot trust to do self-care, who need help with, going to the bathroom, they need assistance with getting up. They can't be isolated. They cannot isolate them for a few days.
Yeah,
those are practical considerations which are not mentioned in any of the. Obviously, the clinical trial population is different, so we maybe need a real-world study on these radiopharmaceuticals in some ways.